Hello, everybody. My name is Gail Robos. I am a professor of medicine and director of the leukemia program at Weill Cornell Medicine in New York City. It is my great pleasure to be hosting and sharing this webinar on understanding the differences between FLT3-ITD and TKD mutations in AML, implications for clinical practice.
Thank you for giving me the opportunity to review with you FLT3 mutations in AML, the types, prevalence, and clinical significance. FLT3 is a member of the type 3 receptor tyrosine kinase subfamily, which includes the KIT, CFMS, and PDGFR alpha and beta. And this receptor is essential for proliferation and differentiation of myeloid progenitor cells, and its expression decreases as myeloid cells progress to their terminally differentiated states. On the right of the slide, you can see the summarized structure of the FLT3 receptor with extracellular, transmembrane, juxtamembrane, and tyrosine kinase domains. In normal circumstances, FLT3 is a monomer which is inactive, and when the ligand is linked to the receptor, it becomes a dimer and activates signaling downstream. Approximately 1/3 of patients with AML and 30 to 40% of cases with APL, of patients with APL, have FLT3 mutations. And there are two types of FLT3 mutations. On the right, you can see that one type is the internal tandem duplication of 3 or more than hundreds nucleotides, and this is accounts for approximately 25% of cases. And the other type of mutations are point mutations that lead to the substitution at codon aspartate to 835. And these are mutations in the TKD domain. The mutations FLT3-ITD can be in general in the juxtamembrane domain and least frequently in the beginning of the TKD. The mutations lead to constitutive activation of the receptor and the signaling of different pathways downstream, mainly PI3K-AKT, JAK-STAT, and RAS-RAF-MEK, and this leads to active proliferation of the leukemic cells and some degree of inhibition of apoptosis. FLT3 mutations are associated to high blood cell counts and to a high relapse rate. You can see here from two large series the frequency of mutations and showing that in patients up to 65 years old, this is a series from the AML-SG with more than 1,500 patients intensively treated, and FLT3 mutations were the most frequent observed. In patients above 65 years old, and this is a series from the AFA AML-001 trial comparing azacitidine with conventional care, we can see that the most frequent mutation is VNMT3A, followed by TET2, IDH, TP53, RANKS1, MPN1, and FLT3 is the 7th in frequency. On the bottom right, you can see that FLT3 mutations decrease across age group, with the maximal frequency in patients below 55 and lower frequency, the lowest in patients 70 years or older. FLT3 mutations usually associate to co-mutations. And you can see on the top of the slide on the left that the most frequent co-mutations involve NPM1, DNMT3A, VT1, and TEPA. And it is very important to look for co-mutations in patients with FLT3 positive AML, because some associations have a prognostic impact. For example, the association of FLT3-ITD, NPM1 mutation, and DNMT3A lead to a poor prognosis. And interestingly, the recent Quantum First trial has shown that this subgroup of adverse prognosis with triple mutation significantly benefit from the addition of quizartinib to intensive chemotherapy. There are several methods to detect FLT3 mutations in clinical practice. Nowadays, the most frequently used are fluorescence-labeled PCR with restriction fragment analysis, and this has a sensitivity of 5% and a very short turnaround time of 3 days. And the other technique, which is now widely used in clinical laboratories, is multiplex targeted NGS with higher sensitivity but longer turnaround time. Targeted NGS is useful because also can give us information on commutation, and also because it may detect FLT3 mutations beyond the hotspot regions. NGS for FLT3-ITD has shown to be very important to investigate minimal residual disease. Here you have 3 examples. On the top left, we have the HOVON experience after 2 induction courses, showing that patients with persistent MRD by NGS had increased relapse rate and lower survival. On the bottom, you can see the AMLSG showing the same finding after 2 courses of chemotherapy with midostaurin, increased relapse rate if there is FLT3-ITD, minimal residual disease, and lower survival. And on the top right, you can see the CIBMTR experience showing that patients with MRD before allogeneic transplant have increased relapse incidence and lower survival. What are the common characteristics of patients with FLT3 mutations? Here we have our own series with more than 200 patients in 2 consecutive periods, and you see that the median white blood cell count is high, around 45 to 53,000 leukocytes, that patients mostly belong to the intermediate cytogenetic groups, and that FLT3-ITD is much more common than TKD. This was particularly in the first period, that concomitant NPM1 mutation is observed in more than 65% of the cases, and that mainly FLT3-ITD did not affect the complete remission rate that was around 80%. In our series, we were able to transplant almost half of the patients with this mutation in the more recent period. And you see how in the more recent period, that is coincident with the introduction of midostaurin in clinical practice, you see that the survival has improved due to a significant decrease of relapse incidence with the addition of the tyrosine kinase inhibitor. Regarding TKD, and these are data from the ratified trial, these patients have a less prominent leukocytosis. Also, NPM1 co-mutation is very frequent, and most patients belong to have a normal karyotype, and also in the complete remission rate in the ratified was lower than the one I showed in my previous slide from our experience. And in that trial, almost 40% also were transplanted. Let's move to the categorization of prognosis. And this is the European Leukemia Net 2022 risk categories, genetic risk categories for patients fit for intensive therapy. And in contrast to previous ELN versions, all patients with FLT3-ITD are in the intermediate risk category. TKD is not considered in this classification. As we move to the ELN 2024 risk classification for patients receiving less intensive therapy, mainly venetoclax azacitidine and ivosidenib azacitidine, the patients with FLT3-ITD without mutation in TP53 are classified also as intermediate risk. Some details or more studies in deep about the prognosis of FLT3-ITD in AML. So there is an important study from AMLSG by Rucker et al. Showing that patients with ITD in the tyrosine kinase domain 1 SOL had worse survival than those with mutation in the juxtamembrane domain or mutation in the juxtamembrane domain and TKD domain. The impact of internal tandem duplication length has been studied, and the most recent analysis with the largest number of patients has shown that does not have prognostic impact, and currently it is being investigated the prognostic impact of FLT3-ITD microclones with an allelic burden between 0.01 and 0.05, and you will see the results of this study at the next meeting in ASH. The presence of microclones could be in part the reason why a recent randomized phase 2 trial has interestingly shown that the addition to quizartinib to a standard chemotherapy was associated with a significant longer event-free survival and overall survival than placebo in patients with wild-type FLT3 AML, so with negative ITD. If we analyze the prognostic impact of TKD, this large meta-analysis shows that there is no impact in survival in general. But TKD, it's also important because associated to NPM1 identifies a group with a very good prognosis, the co-mutations TKD and NPM1, and also patients with CBF and TKD mutation also have highly favorable prognosis. Studying FLT3 mutation is also important in relapse because of patients who have FLT3 mutation at diagnosis, between 0.0 and 11% will become FLT3 negative at relapse, and because patients who are FLT3 negative at diagnosis, and more importantly, 5 to 30% of patients will become FLT3 positive. So this emphasizes the impact, the relevance of doing studies at relapse. And this has also been shown in 3 cooperative group studies indicating that FLT3 is prognostic in relapse. So in conclusions, it is important to investigate FLT3 mutation status at diagnosis, to monitor MRD and to test at relapse. 1/3 of people with AML will harbor FLT3-ITD or TKD mutations. Co-mutations are frequent, particularly involving NPM1 and DNMT3A. ELN genetic risk classifications categorize FLT3-ITD in the intermediate risk group, both in patients intensively treated and in those with less intensive therapy. Overall, TKD mutations do not impact prognosis, and the introduction of FLT3 inhibitors has improved the outcome of AML patients with this mutation. Thank you very much.